Good morning, everyone, and good evening for our speaker, Professor Gur, and our colleagues in India as well. Welcome to our Buncke Clinic series of virtual visiting professors. We are delighted today to have another world-renowned expert, a dear friend of ours, Professor Eyal Gur, and he will be discussing reconstruction of the paralyzed face, a topic for which he is obviously known around the world. He is director of the Department of Reconstructive and Aesthetic Surgery at the Tel Aviv Sourasky Medical Center. A couple of background, there we go, information about Dr. Gur. He attended medical school at the Sackler Medical School at the Tel Aviv University, and he also completed his plastic surgery residency at Tel Aviv Medical Center. After that, as we all know, he spent 2 full years in Toronto, focusing on all aspects of pediatric surgery, including craniofacial surgery, and spent a fair amount of time with Dr. Ron Zucker, who, as we know, is also a thought leader in the field of facial paralysis. Upon returning to Israel, he established the microsurgery unit at the hospital, also a multidisciplinary craniofacial center and cleft lip and palate team. And his main field of clinical research, as we know, is facial paralysis, but also he's involved in breast reconstruction from a basic science standpoint. He has done basic science research in the field of ECA, peripheral nerve regeneration, and also new advances in whole organ cryopreservation. So really many areas of expertise, and he does a lot more than what we think of with facial reanimation and reconstruction of the paralyzed face. He is a past president of the Israeli Society for Plastic and Aesthetic Surgery. And obviously, as I mentioned, he is internationally renowned in the field of facial paralysis, and we're lucky to have him share his expertise with us here this morning, or this evening for many of you. With that said, Eyal, thank you so much again for joining us, and it's really a pleasure and an honor to have you.
Thank you so much, Babak.
And I am going to now, I'm sorry, go ahead.
Yeah. Mm-hmm.
Okay, I'm going to give you control now. You should see a prompt that you've been made the presenter. And then when that happens, on the bottom of the screen, you will see a screen button. And when you screen,
where there's a share, an orange share button on the right side under my video. Is that the share? Is that what you mean? Screen.
Eyal, I think that sounds good. Try that.
Excuse me?
My GoToMeeting froze. Sorry about that. I opened it with my phone here. Let me see if I can give you control now. Sorry.
Okay.
I'm using my phone now, so let's see here. A little technical difficulty. Where are you? There you are. And make presenter. Okay, so you should see the.
Yeah, I see that now. Yeah. So a share button on the right side.
Yeah, if you share the screen, we should be able to see your screen.
Let's see. Let me see just a second. Do you see my screen?
Yes, we see your screen. It looks perfect.
Okay, good. So, good morning, everybody. Good evening to India fellows. And thank you so much for asking me to talk here today. As said, I come from Tel Aviv, Israel. As said, I'm the chief of the Plastic and Reconstructive Surgery Department at the Tel Aviv Medical Center, which is the largest and the proudly most advanced department in our country. We have 13 on staff and another 15 residents. And we deal with most aspects of plastic surgery, from dermatosurgery through general reconstruction, breast reconstruction, alloplastic, and autogenous reconstructions. We have a large micro unit that deals with orthopedic oncology, head and neck oncology, lymphedema, and the facial paralysis field within it. We have a pediatric plastic surgery unit, a post-bariatric surgery unit, breast aesthetics units, meaning reductions and asymmetries. So we're spread on most of aspects of plastic surgery, and I'm very proud to be the chief of this wonderful group of surgeons and students that we raise there. Babak, do you still hear me?
Yes, we can hear you, and your screen looks perfect as well.
Okay, excellent. So I will start with my talk with really no disclosure about the field, the topic that we're talking about. And this is the Tel Aviv Medical Center right here, with the main building where we are located just under the heliport. This is the pediatric hospital. This is the old hospital, and this is the outpatient clinic section. And that is the Mediterranean Sea there in the distance. Well, I know much about the significance of the smile from the smiles of these two fellows who were my mentors, Ron Zucker here and Peter Nelligan, whom I've spent my second year in Toronto doing head and neck oncology, microsurgery, reconstruction. And those were two very smiley faces that had helped me to achieve my goal, go back to Israel and establish a microsurgery unit and a pediatric unit as well. What is a smile? A smile is, as the Webster Dictionary tells us, it is a facial expression in which the eyes brighten. Look at that, it is so important. The eyes brighten before it tells us that the corners of the mouth curve slightly upward. And this expresses amusement, pleasure, approval. So Naama, my daughter, we could see her eyes there, or Ido, look at those eyes. Is he smiling or not? He is. Or Ossi, my partner, is she happy? Yes, very happy. So the eyes come first and then the mouth. Well, the problem is that we can do a lot about the mouth, but we can hardly do anything about the glimpse, the happy glimpse of the eyes. But what's the significance of the facial nerves in terms of function in psychology? Of course, as you all know, the orifice controls. If there's lack of control, then we have dryness of the eye. We can get to complete blindness due to conjunctival keratoconjunctivitis, and dysfunction of the mouth orifice can lead to drooling, speech, and mastication issues. A very main issue is the psychosocial effect of lacking of a facial nerve, and that leads to the major hurdles at self-image and self-confidence, with abstaining interpersonal interactions, and all in all impaired well-being, as we all know, and know those patients here who we can see on the side here. Well, when I approach patients with facial paralysis, there are several issues I would like to explore and know before I build the surgical or treatment plan. It is important to understand the cause and duration of the paralysis. I will talk about it. The patient's age relating to nerve growth and what's the implications of that. There are two very important questions in terms of decision making. Is the ipsilateral nerve, the nerve on the side of paralysis, is it functional or non-functional? So we'll be able to know if we can use it or not. And are there viable muscles on the affected side? For the first 2 years from paralysis, those muscles, if they were not resected at surgery, they can be reanimated. Another question is there a functioning or non-functioning contralateral facial nerve in case where the ipsilateral facial nerve is not there or cannot be used? And of course, we have to look at the patient's own needs and desires, the patients and patients' families and social supporters. So in terms of an algorithm, I did not, put it as a diagrammatic algorithm, but in terms of when we have a viable facial nerve and the viable facial muscles, we could do a primary nerve repair. We could do an ipsilateral nerve graft if there's a gap. But if the facial nerve on the affected side is not present, we could do a cross-face nerve graft, combining it with a babysitter procedure, which I will elaborate about later on, or any other of the cranial nerve transfers, the masseter or hypoglossal nerve transfer. In cases when we have a viable or non-viable facial nerve on the affected side, but we don't have muscles anymore, as with a congenital or with a long-standing facial paralysis, the armamentarium of options that we have are a free muscle transfer connected to the ipsilateral facial nerve if there's something still there, or a cross-face nerve graft with a free muscle transfer, which is the flagship of facial paralysis reconstruction that most of us know and use. We could also use a free muscle transfer innervated by another cranial nerve, usually the masseter, or two other options that I don't use a regional muscle transposition, although Dr. Labbe had revived the use of temporalis muscle transfer. And with patients who are old enough, sick enough, who do not wish to undergo very complex procedure, we'll do a static facial reconstruction. So all in all, this is our experience, just a list of numbers showing that we do enough to use our data and learn from it and learn how to improve. So just to show you a variety of cases, before I talk about true innovations, a variety of cases of what do we do in the unit, the facial paralysis reconstruction unit. So of course, basic stuff, dynamic reconstruction with immediate nerve coaptation after a glass injury, glass laceration with primary coaptation. Or after acute injury, a 15-year-old who rode his bike and got hit by a car. He showed in that way with a huge deep laceration of his right side. This is at expiration, disconnection of main buccal zygomatic branches, rerouting them with a sural nerve graft, and that is him before. And you can see the complete paralysis on that side. And that is him after 3 months. Good brow lift, eye closure, some synkinesis, good smile. So basically, this is the right way to go with exploring and nerve coaptation and nerve grafting. We do immediate reconstructions with the head and neck oncology after parotid tumor resection, like rerouting the complete branches of the tree branches of the facial nerve with sural nerve grafts. And that is another example of a patient who was referred to us by ENT after cholesteatoma. Just a second, go back. After cholesteatoma surgery, where at surgery the surgeon had noticed that he had injured the facial nerve at the middle ear. We got in 2 days later, that was him. 2 days after the cholesteatoma surgery, complete facial paralysis. We've nerve grafted it inside the middle ear, and it put a vascularized temporoparietal fascia inside, so this nerve can survive in a bony tunnel, and that is him 6 months after. Just a second. So you can see a good smile, some synkinesis, but immediate reconstruction. This is a patient with a base of skull tumor that was resected, and she ended up with a complete facial paralysis and a 6th nerve paralysis as well. I saw her when she was about 11 months after her brain surgery, and I've elected to do a complex procedure, which was called by Julia Terzis a babysitter procedure. So we've connected the Masseter motor branch to the facial nerve here, and then added 2 cross-face nerve grafts. Are we okay? How about?
Yes, we're okay. We can hear you now.
And that is Noah, that's her name, after the 2 cross-face nerve grafts had started to act as well. So we have very good tone driven by the master bench and nice smile active. When the masseter takes over, it is very hard for the cross-face nerve graft to take over. Baba, I have an echo. Are you okay with that?
Yeah, I just found another person's mic that was on, so I just turned it off. Please turn all your microphones off. Thank you so much.
Thanks. Anyway, when the masseter motor branch takes over, it is very, very hard for any other weaker nerve to interfere and takes its place. So the question was always, after we have a cross-face nerve graft, do we go back and transect the masseter motor nerve with its very intense motion? Well, it is very hard to decide on such an action. And out of the 8 patients where I've performed the babysitter procedure, she was the only really successful one. In most of them, I moved on, and at the third stage, I've inserted a Gracilis muscle and connected it to one of those cross-face nerve grafts that were primarily implanted. But as you can see, that are photos that she sent me from her wedding and then from with her boy. The smile is truly spontaneous, and it comes from the contralateral side. So that takes to long facial paralysis with the flagship, of this reconstruction, the cross-face nerve graft and a free Masseter transfer. So we know that a true smile will be spontaneous and will be expressed in a true way, mainly if we use the facial, the 7th nerve. And the main part that we're able to reconstruct today is the zygomaticus major and minor complex, which are very, very important for the well-being, for interpersonal interconnection of those poor patients. Of course, there's various muscles that were used in the past, pectoralis minor, segment of the latissimus dorsi, but the gracilis is truly an optimal muscle for that purpose. So the first stage, we start with a cross-face nerve graft, harvested through very small incisions. We try to harvest the muscle from proximal to distal. So if we need only that segment here, do you see my marker, my arrow?
Yes, we can see your mouse.
Yes. So if we are able to use that segment, we may have some nerves, some sensory nerves coming from the peroneal, cutaneous peroneal nerve. So we are about not to lose the sensation that is typical for a sural nerve harvest. Sometimes we have to go further than that when we need longer nerve grafts. Um, and then we go and explore the normal side. We find two branches that are in the distribution that give a smile in the distribution of the zygomaticus minor and major. And we will select the appropriate branch that gives a good smile but is minor to a large branch that we keep in place so we do not damage the smile, the action on the normal side. This is, in the past, I used to explore all those nerves, all those branches. Today, I go only from the lower part of zygomatic arch to the Stenson duct, and within this centimeter and a half, I will usually find more than two branches that gives a nice smile, and those smiles should be solely smiles with hardly any orbicularis oculi action, which is sometimes hard to find. So these are two of those branches. And as we can see, this is the smaller one that gives a nice twitch of the zygomaticus major minor. And this is the larger one that gives the same action here. So we're able to transect the upper one with hardly any orbital oculi action. At the second stage, that takes about 7 months later, we will harvest a mini gracilis muscle weighing between 8 to 14 grams, depending on the patient, and we'll complete surgery by placing it from the modulus to very high at the superficial temporal fascia, connected to the facial artery and vein, and to the cross face that we've inserted 7 months before. Anastomosis will be through the buccal mucosa at the buccal sulcus. And this is Jon, and a very smart and brave guy before surgery and at the age of 13. Not super good symmetry, but nice smile, no eye motion. This is Ziv before, and this is him after. A nice smile, nice excursion, too deep nasolabial fold. And this is Moshe with Bell's palsy, post-Bell's palsy on the right side. And this is him after a two-stage reconstruction. And Tammy went to a military exhibition where a heavy metal fell on her head. She suffered base of skull injury with the right facial paralysis. Luckily, the eye was not damaged. A two-stage cross-face and gracilis muscle gave her a nice excursion and symmetry. This patient is interesting because everything was much more complex. This patient, Irena, went irradiation for choroid oropharyngioma of the mandible, ended with the osteoradial necrosis of the mandible. As you can see here, there's a sinus that drains pus, lots of pain. Really, it was really hard for her to speak or eat with the breaking with the bone that broke on her mandible. To choose a nice obscured donor site, we tried to reconstruct with the Iliac crest. It failed the next day, and then we moved to a fibula a week after. That was successful, but unfortunately, a year after, she came in, just a second, she came in with squamous cell carcinoma of the tongue. So she had free radial forearm flap for reconstruction. And at that surgery, when the plates were opened and re-screwed by the ENT surgeons, there was some injury to the facial nerve. The neck, the face and the neck was irradiated from her oropharyngioma therapy, so it was impossible to go back to that side of the face because of variation, because of the 3 free flaps that were applied there. Iliac, crest, fibula, and then a radial forearm flap connected to the pedicle of the pedicle of the fibula. And still, this lady who passed, a horror path to health, asked for facial nerve reconstruction, and that is her before surgery. So the idea was then go to the contralateral neck and do, first do a cross-face nerve graft, wait 9 months, go to the contralateral healthy vessels, create an AV loop to the affected side, and transfer a free Gracilis flap there. And that is her after we've completed this Via Dolorosa. And you can see a successful reanimation to the irradiated, reoperated face. For older people where nerve growth is very slow, and that is beyond the age of 50, in my view, we do a one-stage Gracilis free flap transfer and connect it to the Masseter motor nerve. And we can see Israel here before, and that is him right after, with a nice excursion and nice use of the muscle, although not spontaneous smile. And this is Miriam before. She's too shy to smile, and that is her after, with a nice pull of the oral commissure. And that takes us to the last, option here, a bilateral Gracilis to Masseter motor nerve with a bilateral facial paralysis, and the Möbius kids is a representative of that group, before and after, and first side and second side. And that is Matan before. Some lower lip depressors are effective, and that is him right after these 2 stages. And that is him at the age of 16 coming for minor revisions and fat injection to the lips. So when I've left Toronto, Ron Zucker given a talk at that time in the World Society of Microsurgery, and that is basically his slide. And he had spoke about challenges and future tasks in facial paralysis reconstruction. And I've copied that slide, and I've, at first, for the first 10 years, I've just tried to be good enough and do enough procedures and patients and learn how to, really refine the techniques that I know. But with time, I've tried to relate to the fields that we lack solutions in. For example, the eye. We hardly have any dynamic options for eye reconstruction. We have Julia Terz's muscle neurotization with transfer of the platysma or the frontalis. We have some minor achievements here and there. I wanted to find some solution in that field. I wanted to find solutions for reinnervation problems with the massive synkinesis that we see with patients, and we hardly know how to relate to that. The concept about incomplete facial paralysis was do not touch. If you touch, you'll injure what the patient still has. So incomplete paralysis had no solutions. And what can you do about the consistency of your results? How can you improve symmetry, excursion, nasolabial fold creation, etc.? There are lots of other stuff that are to be solved, but I've tried to relate to those issues marked in yellow. So reanimation of the eye. This is Lidar, and Lidar is before, she's after AVM surgery to her brain with residual facial paralysis here. Very nice, very smart, very frustrated, and that is her after a cross-face nerve graft and a gracilis muscle transfer here. But I want you to see that although the smile is very delicate and nice, the stigmata of the open eye is so horrible and frustrating, and truly there isn't any good solution for the dynamics of her eye. And then several years ago, I've met that patient here with unilateral facial paralysis on the left side, and the situation long-standing, and the situation was so bad that the oculoplastic surgeons had taken a piece of hard palate mucosa and inserted it to her lower eyelid to prevent her from drying. And she came to us, and we've decided to operate on her. And the idea was take 2 cross-face nerve grafts, one in an eye distribution, orbicularis oculi distribution, and then another nerve graft from a buccal, zygomatic buccal branch for the smile. Take the gracilis muscle and split it into 2 units based on the same vascular leash, but connect the cross-face nerve grafts to the transected nerve, obturator nerve, the cross-face nerve graft from the smile to the smile, from the eye to the eye. And that is at surgery. This is the gracilis, and this is the segment that we've spared here based on the same vascular leash, but transected nerve, and we can see some twitches of that muscle. It is not that reactive because in order to put it at the lower eyelid, we have, and I call it, it's a funny name, to prosciuttomize it, to make it so thin that it goes in without any major bulk to the lower eyelid. So that is the muscle for the smile, and that is the muscle for the orbicularis oculi replacement, and you can see the twitches, and that is an inset. And here, that is her before, and that is her with mechanical tapping on the muscle 2 months after surgery, and we can see the twitches here, that it twitches, and that is her right after 8 months when everything starts to move, and then eyes goes up, and you can see the wrinkles that show here, showing that there's a nice closure, at least pushing up of the lower eyelid. So that is something new that we were thinking about. We have already 6 patients that we've operated on, 3 already with a nice or better eye closure, and 3 are still on the way. The idea is, why not go further on and create 3 segments, and 2 segments for the eye and 1 segment for the smile. And that is the future plan. It will be much harder to place a muscle not over the tarsus, but over the septum of the upper eyelid. But this is our next task in terms of innovations and dynamics of the eye. What about consistency of aesthetic results and symmetry revisions? At first, truly everybody were really very skeptic from going back with the danger of injuring the vascular anastomosis and the nerve anastomosis that we've done to the face. But today we're much more permissive in going back, dissecting the muscle up to the modulus, connecting some stitches or adhesions by the modulus or by the nasolabial fold to create a better nasolabial fold or a better pull of the oral commissure. So that is the muscle, a dissection up to the oral commissure. Or with other issues like adhesion of the gracilis muscle to the cheek, when this is a mistake. I guess that the dissection was too superficial with exposure of dermis, and then the dermis got adherent to the muscle. So we go back, we dissect above the muscle, we can insert a little fascia with fat on that area and go out and bring it back to that situation here. And sometimes we do that only with fat injections. And what about incomplete facial paralysis? Should we go back? Should we go into those phases and hopefully not injure the functioning nerves that are still acting there? So look at that lady here. A nice smile, normal smile on the right side. Hardly any smile on the left side, but there's a nice twitch here. Look at that. That creates nasolabial fold without any effect on the mouth. Or look at that kid here. And you can see that there's hardly any smile. There's twitch at the zygomatic area. There's a close-up for that. And you can see that it moves here, but the oral culture doesn't move at all. And when I've done that case, I've realized that we can relate to those patients in a different way. And this is a method that we have created, we published, and we try and spread it around. And people really are very happy to accept it. This patient had dermatofibrosarcoma of his cheek, created and needed a major resection of parts of his skin, nasal wall, maxilla into the nasal cavity here. We've created a huge cervicofacial flap here and had taken the gracilis muscle, connected its fascia to the opening of the nasal cavity so we could obliterate it, and connected the muscle to the superficial temporal vessels here, but to the cut endings of the facial nerve that were transected here, and then covered everything with the cervicofacial flap and a forward flap for the nasal side. So that is him after a year, and because a very nice excursion of the gracilis muscle to the upper lip. So if this can work, why not go back and treat incomplete facial paralysis with those residual nerves that are still there in the face? This is Jacob. I don't have a video of him, but you can see his facial paralysis. But when I've examined him, I've evidenced some little twitch here, right at just under the zygoma. So I've decided to take one of those residual nerves that still create that twitch, connect it to the muscle at a one stage, gracilis to the ipsilateral residual nerve, and luckily and happily, we got that result. A very fast and nice excursion of the gracilis muscle, creating a very natural smile created by the ipsilateral natural nerve. So this nerve was waiting for a new muscle bulk, a new motor unit to work on. It was there, it was waiting, but did not act on anything because probably his muscles were injured or atrophied with time. So we have applied that to other patients with incomplete facial paralysis with some rules. We limit the zone of dissection so we will not damage other functioning branches on the affected side. We connect to the superficial temporal vessels so we don't have to dissect down to the facial vessels here, not injure the marginal mandibular if it is still functioning. We'll use one of the two nearly always existing minor branches that gives that twitch, and we use stitches as we do with gracilis muscle anchoring to the modulus and upper lip. One very interesting thing when we go into those phases and try to use the nerve and stimulate them, we find a much more vast action of those muscles than we see clinically. So when you go in, there's nice twitch of those muscles giving you a nice smile, but at clinical examination, they hardly move. So these nerves can be selected, at least one of them, for that purpose. And that is him from the outside. So there's a nice motion that you could not see when you asked that kid to smile. Again, we transfer a mini Gracilis to those patients. And some examples, that patient you've seen before with a little twitch here, and that is her right after, with a nice nasal fold, a nice excursion of the modulus, the oral commissure. Another patient who underwent previous surgery at the nasolabial fold to try and create some smile, but you can see there's a big twitch here, but hardly any motion of the oral commissure. So I've used that nerve, transferred the Gracilis muscle, and got that nice excursion and nicer smile. And that is a guy with hemifacial hypertrophy due to facial lipomatosis. He was operated by a surgeon intraorally with damage to his facial nerve, and that is him after Gracilis muscle transfer to the ipsilateral nerve. I could not, of course, better his asymmetry, but at least give him a smile. A girl with a nice smile on the right side, hardly any smile on the left side with some twitch at the zygomatic area, and that is her after. And that kid that you've seen before, with the twitch here at the zygomatic area, that had been used to connect to a Gracilis muscle, happy kid, and even happier after bilateral autoplasty. Bring us to that girl, a very, very sad story of when she was 4, she suffered idiopathic aplastic anemia with sepsis and multiple site fasciitis and large area of necrosis over her back, abdomen, thigh, and a through defect through the lower third of the right cheek, skin, muscles, and mucosa. So you can see her mandible here, her tongue here. We've waited for her, that was ago, we've waited for her to granulate and better in terms of her systemic status. And then we've transferred a free radial forearm flap over here with the major contraction. So we thought that we were smart enough. We've inserted a tissue expander here, expanded it, and tried to replace the radial forearm skin with the neck skin, but we've only created a worse pull and contracture of the oral commissure and the neck. So at the journey back to normality, that was her before surgery, when I've elected to take a free scapular flap and create the defect again, and replace the area with new skin from the back. She had to undergo another about 5 procedures to debulk that, to release contractures from the neck, to release contractures from intraorally, and we got to the stage here where the contour was better, the color match was not good, but she had facial paralysis from the basic insult at the time of her sepsis. So I've transferred a cross-face nerve graft, thinking that it will be really hard to go in here and look for an ipsilateral facial nerve because of the necrosis and the dead muscles that were there. But at the time of surgery, when I went in, I found the nerve. I didn't use the cross-face nerve graft, transferred a Gracilis muscle to the pedicle of the scapular flap, and that is her with a nice smile and excursion. I'll skip that one and go to another area, the area of, I still have another 15 minutes, Bobak?
Yes, you have plenty of time.
Okay, great.
Yeah.
So, what about the synkinesis and the spasms sometimes we have with synkinesis? Sometimes spastic facial mimetics are a devastating condition. It can be treated, and truly it can be treated with the tools that we've created for facial paralysis reconstruction. So we had that girl coming in, and we had found her to suffer from hemifacial myohypertrophy. She had a a very short period of I would say, just a second. I should take a sip. She had a short period of facial paralysis, but then everything just got contracted, and you can see her here. That's a before. Any smile, and sometimes without any intention, everything curls, contracts. Look at her ear. Everything gets into incredible, awful spasm. She looks really, really bad. So we said, okay, let's try that instrument, Botox, an instrument that we use a lot for facial paralysis reconstruction to create symmetry, injecting it to the normal side of the face, and sometimes to treat the synkinetic part, the synkinetic eye or synkinetic platysma muscle. But huge amounts of Botox didn't help that poor girl. And then we had to make a decision. Will we go in, transect her facial muscles, spastic facial muscles, create facial paralysis, and then go to reconstruction? This idea was suggested by David Cheng from Taiwan, but really, I mean, this is a really procedure that damages anything that we know to take facial muscles away. After major discussions with her family, we've decided to go ahead. But going in, we found an amazing findings with a huge, thick platysma. The width of the platysma was about 1 centimeter to 1.5 centimeters, and that is the first procedure where I've taken part of the platysma from her neck. And that is her before. And that is her, and that is her at surgery. And you can see that the muscle moves by itself. It looks like a creature. It moves with spasm, like a wavy form. I'm not sure you can see that, but that's what we saw. So at the second stage, we've taken the muscle from her mid-face. And at the third stage, we've done a huge dissection because her platysma went up to the forehead and to the eye and to the alas of the nose. And that is her right after that surgery, with still some spasm of the eye. And then I gone back, taken some more hypertrophic spastic fibers from around the eye and from her ala nasi. And that is her now. That's her before surgery, that surgery. That is her right after that surgery, still everything swollen. But again, that is her before all that Via Dolorosa. That is her after the third stage. And that is her today after the fourth stage, with nice opening of the eye and no spasm anymore. So facial paralysis reconstruction and the instruments that we use there can really lead us to treat spastic faces, to do selective neurectomies or selective myomectomies or myomotomies as needed. Well, main innovations in facial paralysis emerge from learning from your patient's cohort, and I've mainly learned from errors that I made with my patients, and I will just go through some errors that help me to find out ways how I can do it better. So example there's so many things to discuss and to think about, but for example, heavy faces. If we insert a gracilis muscle to a face, it is hardly noticeable. But this patient lost weight, and you could see a better smile, better noticeable smile with her. What about errors in learning the etiology of injury? Like, for example, this kid. This kid came in with a laceration across his face. So Without questioning furthermore, I went in, inserted a gracilis muscle, and wanted to connect it to the ipsilateral residual nerve. It didn't work because I was not smart enough to understand that at the time of injury, he had a base of skull injury, and the nerve was not healthy at that area at all. So I went to a second stage, a cross-face nerve graft and a gracilis muscle, as you can see here, with another error, with a too horizontal placement of the muscle and a too bulky muscle. What about a too weak or a too weak nerve selection, or an error in selecting the right nerve range? That is Tammy just before, and you can see her right facial paralysis. And that is Tammy right after a cross-face nerve graft and a gracilis muscle transfer. Look at her nose. In order to smile, she had to activate her levator alacnazi. Very, very funny. Please don't make laugh of me, because this is really ugly. But this was easy to correct. The only thing I had to do was inject some Botox at the levator alacnazi and give her that better smile. But what about this guy? Before and after cross-face nerve graft and a gracilis muscle transfer, nothing moves. But look at him when he closes his eye. So nerve selection was wrong. I've taken a zygomatic branch that mainly goes to the eye and gives a nice animation of the gracilis, but only when he closes his eye. Any suggestion what I could do here for a second stage? This is really hard to decide upon that, but I had to transfer another cross-face nerve graft, wait for it to grow and reconnect it. Gracilis muscle, masseter nerve to facial nerve as a nerve transfer gives really bad results. It really keeps the face in a nice mood. That's a before, and that is an after. That's a regular smile, and that is when she clenches her teeth. This is not a nice motion. This is a mass motion of the eye, the smile, the neck. So masseter nerve, selective masseter to ipsilateral facial nerve should be a more selective procedure. And more mistakes that I've learned with time, a too bulky muscle, gone back and reduced its volume. A too loose tone, that's a before, you've seen LIDAR before, and an after. A nice smile, but not enough excursion. We saw that guy. Inability to place the muscle in a way that it will elevate the upper lip. What I'm doing today, part of the muscle, I will insert into some kind of a loop, of a fascia loop, that creates some kind of a lever, so it changes the direction of the muscle to give a better elevation of the upper lip. Or for example, here, a very nice excursion, but inability to elevate your upper lip. I will browse more and more mistakes that I've learned from a gracilis muscle to masseter. Look at her spasm. Masseter nerve is a huge muscle with amazing power, and look what it did to the gracilis muscle. So I had to go back and lengthen the muscle, release it a bit, reduce its size, and got a better result with that, and with some Botox injections as well. And another mistake with that guy that you've seen before, but I've shown you just part of the move, that that is him, smiling very nicely, but with an open mouth, we have to treat the lower lip. Lower lip depressors on the normal side needs to be treated in order to create a better smile and better symmetry. We didn't stop only with our clinical achievements or ideas or explorations. We wanted to know how can we make nerve graft grow better. We have a very nice hyperbaric facility in town, and we thought Dr. Daniel Kedar, whom Buncke you just mentioned, had taken that project with me, and we decided to find how hyperbaric oxygen affects the growth of long nerve grafts. So facial paralysis reconstruction relies on long nerve grafts. Not just that, we have nerve grafts in many fields, and also in allotransplantation as well. So because of the very, very dependent growth, the results are irreliable. So nerve regeneration is vigorously supported by large numbers of trophic factors expressed locally, and prolonged innervation and poor vascularization of the graft affect the environment, and axonal regeneration is impaired. So we thought that maybe HBO could do that. We found some data in the literature that supports that back from the 70s. And the rationale was to give better optimal tissue oxygen pressure that will affect all those factors that help with the healing of tissue. We've set a study with 42 rats. We used the sciatic nerve model. We've taken a sciatic nerve, dissected it in 2 spots, and rotated it in 180 degrees. And then we decided to put them in all the group together in the hyperbaric chamber, 2 atmospheres, 100% oxygen for 60 minutes per session. And those nice patients had 40 sessions 5 times a week for 8 weeks. Like we've adhered to the protocols, the human protocols. We've assessed functional analysis by gait analysis. We've assessed electrophysiologic studies with EMG. We've taken muscle biopsies at the end of the procedures and histologic assessments of the nerves. All in all, there were 3 periods of histologic assessment at POD 14, 35, and 90 days. And all the studies showed no statistical difference, and there was some technical issues, on analyzing gait, EMG, and muscle weight was really very hard to prove any difference. But histology. For histology, we've taken 3 sections: 1 pre-anastomotic, 1 at the mid nerve graft, and 1 post-anastomotic. And we've used NF and CHAT antibodies to show total neurons, and CHAT for functional motor neurons only. What we could see that on postoperative day 14, at the control group, this is the NF, this is the CHAT motor nerves. Before, this is the proximal, this is the middle nerve graft. Sorry. This is before anastomosis, this is the mid nerve graft, this is after the nerve graft. You can see that the control did not have growth at all. With the hyperbaric oxygen at day 15, we started to see some evidence of nerve growth at the stains. At day 35, you can see that the CHAT showed much more nerve regeneration than the control. And at 90 days, we saw almost zero growth at the control, but vast, very, very intense growth of motor neurons at the hyperbaric chamber group. We found the hyperbaric treated rats show a clear trend towards improved axon sprouting and growth, as well as better quality of regeneration. And the pace of the regeneration is greater in the hyperbaric treated rats. We had started a clinical trial, a very, very small scale clinical trial with our patients, with our cross-face nerve grafts patients, after IRB approval, and this study. We've taken this study to a further step, and we've created a facial paralysis model in rats. This is not our photos, but this is ours, and this is our facial paralysis patient here with a facial nerve here. Simulation of the facial nerve shows motion of the whiskers that are measured to the magnitude and amplitude of its motion. And this is a cross-face nerve graft in a rat model. So what's the future for us in terms of facial paralysis? A lot is waiting there. Of course, in the field of allotransplantation, if we will be able to solve issues of rejection and eliminate the use of cytotoxic agents, we'll be able to transplant muscles or nerves from other individuals. Electroneuromotor radio transmitters will be able to put a sensor on the normal side and let it transmit a stimulus to some kind of activator on the paralyzed side and activate a muscle transfer, or even more than that, a trial that we are doing nowadays at our hospital with Bell's palsy patients that are at a stage of recovery. We're putting a little tab just around the auricularis oculi, and with a little battery that sits behind the ear, we give them pulsed stimulations to create a blink effect. We do that with a cross-face nerve graft as well, and this is still to be assessed and learned. And of course, as we say, manipulations on nerve regeneration, as you've seen with the hyperbaric chamber, and more. In conclusion, facial paralysis is a loved and complex field. I mean, there's nothing nicer for me to go there and see a family comes in with the kid, gives them and me his first smile ever. There's nothing more cheerful than that. There's a wide range of psychological, social, physical, and surgical technical conditions and considerations to create a successful static or dynamic aesthetic result. But there's a very wide range of hurdles and problems that endanger patients with major or minor, with its major and minor complications. But all in all, this field, with a small attention, with attention that we have to give to tiny needles, to consider a wide range of factors and ask questions and improvise, sometimes before surgery, sometimes at the time of surgery, and find solutions for those poor patients with this very rewarding field of surgery. Thank you.
Great. Thank you so much, Eyal, for an incredible talk and really a nice, not only overview, but in-depth analysis of what's coming up next, the future of facial reanimation and facial paralysis surgery, and also what's on the horizon. There are a number of questions that I have and also folks from the audience have asked, so I'll take a few minutes. But the first question I wanted to ask you was more of a kind of a general question. You're obviously in Israel, which is a country of roughly
Oh, there's some interruptions, Babak. I couldn't
Yeah,
understand.
I think JJ, if you can turn your mic off. There we go. Okay, good. Okay, so you're in Israel, which is a country of about 9 million. So tell us about going about setting up a practice where you've essentially developed one of the highest volumes in an operation that's somewhat rare. And obviously you have referrals coming from everywhere, but tell us a little bit about how one would go about setting that up.
Um, there's some, historical background to that. History is that Israel was very, very, when I returned from Canada, Israel was very, very poor with solutions in general, in the field of microsurgery in general, in all aspects of microsurgery, specifically in facial paralysis. So, of course, the easiest way is to locate yourself in an area of vacuum where there's nothing happening but you. So this is, not what happens in San Francisco. The idea of first years to collect patient by patient, focus on your technique and focus on optimization of your results. Luckily, we had some approach to media. Nothing that I've really planned, but it came in because it is it's a very hypey thing to bring smiles in this world. Usually, everybody around us, eliminate our smiles. The government, wars, but if you give smile, it is very appealing. So there were several articles in the papers and then on TV. One amazing, this is, it is luck. One amazing report on Newsweek. There was a reporter who would found a Palestinian boy that I've operated on. And, this is really strong. An Israeli creating a smile on a Palestinian boy face. This is really, So, of course, this is, you have to find those little stories, where there's a crying kid that comes in with a smile. That's a very good promotional thing. I'm sorry to be sarcastic, but it is true.
Yeah.
That you can do that through that, and then a mouth to ear that good things are happening there. A lot of attention to every patient. A lot of attention. We live in a very, very strenuous environment. Israel, not like San Francisco, is a very intense country. Tel Aviv is it is a New York style thing. No time. We're looking to make money and avoid interactions. I mean, the idea was a lot of time with the patients, a lot of empathy. And I think that it mainly worked together a large group of patients that created a group of support families of facial paralysis. And from there on, it only streams in also from other countries, from Russia, from the Gulf countries, all over Turkey, etc.
Well, yeah. Congratulations on obviously setting up such an impressive volume of facial reanimation that's unparalleled in most parts of the world. That's really incredible. I have a couple of questions from the audience. There was one question about the technical parts of trying to achieve symmetry in a bilateral Mobius type case. Any tips or tricks you have in an effort to, you don't have a normal side to try to balance it. So how do you go about trying to get symmetry with that?
Well, that is strange because to get symmetry with Mobius kids or patients, humbly to say, it is much, much easier to get symmetry than to get symmetries in patients with a normal side on the contralateral side, where they have all their 18 muscles functioning there and pulling in all sorts of different directions. So if you're very precise, if you're taking the same size of muscle, orienting it in the same direction, and it will always be that the most lateral part of the gracilis, lateral and lower edge of the gracilis, will sit on the helical takeoff, just above the helical takeoff. This is the right direction in placing the right tension, of course. And the right tension is pulling the muscle gradually until you see a very, very, very slight motion of the oral commissure. So this is the right resting tone of that muscle. You have to place your suture there. So I think this is the clue to get symmetry. But again, the easiest thing in facial paralysis reconstruction, symmetry, is to get it with the Möbius kids.
Got it. Good. Thank you for that. A question about using the Masseter as a donor for the Gracilis. At what stage, how long does it take these patients to be able to achieve some kind of spontaneity in their smile, or are they able to ever achieve that?
So first, to get action at all, 3 months. 3 months to 6 months, but very, very fast. To get spontaneous, or at least to get a glimpse of spontaneous action, it takes intelligence, not time. I think that you need an understanding patient, someone that understands what's happening there, that uses his muscle in the right timing, at the right, that he knows how to create symmetry on the other side, uses his muscle, and then within, I would say, 2 years, not less, he hardly thinks about it, and is able to smile even without closing his teeth. Well, if you can try and put your masseter muscle in tone even without closing your teeth. So these guys have to understand internally how to do that. But that is with all facial paralysis patients. If a patient is non-intelligent, at least does not understand what it takes from him in order to smile, then you will have disappointment.
Yeah, I can definitely see that. I think the same is true with many of our nerve transfers and functional muscles in the extremities as well. I think that's a great point. So it makes sense. And speaking of which, I was talking to Daniel when I was in Korea last year about your research in hyperbaric oxygen for nerve regeneration. And I was really excited to hear that, because I think the implications of that and the applications of it in what we do in the extremities as well, I think is tremendous. And so I want to first congratulate you on having the idea, and second, on carrying out the study. And I really look forward to following the results.
Well, first I have to apologize to Greg, because I've promised to connect him right after last ASRM and trying to explore ways how to collaborate. But then I went to Brazil, and then Corona came in. So Greg, please excuse me, and let's try to see what we can do together, Balbak as well. So we will let you know about our results. We'll let you know about what we do, and let's see if we could really do something together. I will be delighted to have some collaboration in that field.
Yeah, it's such if it does pan out in the clinical trials, it will be a really exciting, I think, advancement, because as you know, especially with mixed and motor nerves, it's a real clinical problem. The other part of your talk that really struck me was the reanimation of the eye. As we know, from an aesthetic and a functional standpoint, that is a major kind of unsolved problem in many practices. And I wanted to congratulate you on the refinement of the gracilis muscle and being able to harvest these very small portions of it to perform different functions. With regards to the both upper and lower lid, how far do you think we are from being able to see a potential result of that?
More than a year from now. I have a next candidate coming next month, and another advancements that we will have once everything is functioning. We will be able to put this pacemaker, this very thin tab, hardly noticeable on those muscles, and create also blink. And so hopefully we'll get an advancement with that as well, and hopefully we'll be able to show you results within a year and a half from now.
Excellent. We're looking forward to that because that's really, I think, the next level. You've really advanced it even more than I knew about. Another question from the audience that just got posted. Any thoughts on the hypoglossal nerve as a donor in any of the conditions that you see with facial paralysis?
First, disclosure, I don't transfer hypoglossal nerves. Hypoglossal to facial as babysitter, as was used to do by mostly ENT surgeons in the past, the results that I've seen were really bad. At first with tongue morbidity, and then they've transferred to split hypoglossal and nerve grafting, which made that better. But then the bulky, the mass motion, as I've shown you, that my poor results with the Masseter to facial, and then I've refined them. And the mass motion was really bad with the hypoglossal. I think that the instinct of moving your tongue in order to create motion is less spontaneous or less natural than clenching your teeth in order to smile. So I find that the Masseter is a better option, although when there's no Masseter, when there's no facial, this is the next level.
Got it.
By the way, another optional innovation that I did not use yet is a cross-face masseter nerve. If you have issues with masseter on the affected side, you can do a cross-face masseter and connect it to facial nerve or to gracilis muscle.
Great. That's another great point. And then just one last question before we wrap up. There was a few questions about the technical details of splitting the gracilis into these smaller segments. Can you elaborate on whether you do this in situ with the gracilis muscle in the thigh, or if you do it on the back table, if you use a microscope, kind of just a couple of technical pearls on doing that?
Well, I do it in situ when everything is still bleeding and pulsing. It is easier than thought. Each one that does gracilis muscle harvest for facial reanimation that takes just part, a third or a quarter of the muscle width, knows how to dissect those segments from the main muscle that is intended for the smile. So when you dissect that under the muscle, you'll find the network of your vascular pedicle and nerve. It is so easy to take out the mid portion and leave the distal portion, that tiny distal portion. The other thing is to thin that muscle. So at first I've done it under the microscope because I was really concerned that it will not function. Today, I do it using the Buncke and tenotomy scissors. Just take half its thickness or more than that, leave a very slim layer of fibers that will, there's still blood supply, there's still innervation. It will work, even if it will look bitten. By the end of that harvest, it will function well.
Great. No, thank you for those technical tips. And the last thing I want to say is just a comment. I think we've had a number of master surgeons these past few weeks give talks on their respective specialties. And a common theme that we see is that all the surgeons who are able to achieve this level of mastery that you've shown today are also able to show their early results and mistakes that potentially they made and refinements that they were able to make based on their observations. So I think for those in the audience, we all recognize that's what it takes to become a master and get the results that you're showing today. So I just wanted to comment on that. So thank you for that.
Thank you. Thank you for that. I think it is a truly, you know, without assessing your mistakes, I wouldn't go to any innovation, or I would not really better my skills. So I believe that you need to do that, and you need to talk and show it.
Right. Great. Well, I'm going to go ahead and wrap things up. Eyal, thank you so much for taking the time to
Thank you, everybody.
share your experience with us. We hit a maximum of 115 viewers, and we had viewers from Stanford, UCSF, Brown on the East Coast, India, the UK, and also South Africa. And I may have missed some other places. So that just speaks to people really wanting to hear your expertise. So thanks again for joining us. Appreciate that.
Thank you so much for the invitation. I was really complimented by that, and thank you, Babak. Thank you, Greg, for asking me to talk. And I hope to see you soon, maybe in Hawaii or in Cancun.
Hopefully.
In the WSRM. Yeah.
Hopefully. Thank you so much. Take care of yourself. Stay safe.
Bye bye. Bye bye.
Okay, bye.